Yes, thank you very much for the invitation. And I would just say that, maybe particularly for the ladies in the audience, that today is the 125th anniversary of women getting the vote in New Zealand. So it's a very So it's an absolute pleasure to be here. And, you know, when David asked me to do this talk, it immediately took me back to the very first patient that I saw with an aortic dissection. And it's an interesting thing about medicine. I think all of us here would have very clear recollections of particular patients. You know, somebody who really stands out in your mind. And I remember this gentleman. He was a 50-year-old Māori gentleman who came in with terrible back pain. And I was a relatively young registrar, this would have been 18 odd years ago, at Middlemore Hospital. And I remember thinking, gosh, I'm sure this guy's got kidney stones. You know, he's got pain in his back and he looks sweaty and he's a little bit, you know, he's only young. I'm sure he's got kidney stones. But something just wasn't right. He didn't want to lie down. He was really uncomfortable. Nothing I could do was make him comfortable. And so I bailed up my senior consultant and I said, look, this really doesn't feel right, you know. And very fortunately, this guy dropped everything that he was doing and said, right, I'm going to come and see this patient with you. And he also had a look at this and said, no, it's definitely not right, felt his pulses, looked at his blood pressure and said, no, this guy's got a dissection. And it sticks in my mind because I came very close to not diagnosing that gentleman properly. And he also did very well. So it was a lucky day and I guess a memorable one for me. So again, thanks for having me here. I'm actually going to talk a little bit about diagnosis in general and a little bit about aortic dissection in particular, because I think it's quite important to understand a little bit about how doctors' brains work as they try and make a decision about a diagnosis. So I work in Waikato Emergency Department and Thames Emergency Department. We see about 250, 300 patients every day through the emergency department in Waikato. We see about 30 patients a day out in Thames. Now, of those patients, about 30 of them will have chest pain. And a number more will have stroke-like symptoms. And you know, there'll be a huge range of patients who we see. And our job is to decide what investigations that patient needs, whether or not their condition is life-threatening, and who to call in a relatively constrained environment, you know, because there is only so much health dollars to spend and there is only so many of us. So you can see I've put a few other serious causes for chest pain, and as David said earlier, you know, we will see a lot more heart attacks than we will see aortic dissections. I've seen 4 diagnoses 4 times in my practicing lifetime, which, you know, over 20 odd years. So that's 1 every 5 years. Not that many. So we're thinking when the chest pain, heart attack, blood clot to the lungs. Could the lung be collapsed? Could it be a chest infection? Could you have a rupture of the food pipe in the esophagus? Could there be fluid or on the heart or on the lungs? So what happens when you come to the emergency department? And I guess I'm looking particularly at chest pain because I want to narrow it down a little bit for us. When you come to the emergency department with chest pain, you see a triage nurse, and those triage nurses are highly skilled nurses who are trained to, in a very short period of time, 2 to 5 minutes, decide how fast that patient needs to be seen. What's the possible diagnosis? And they've got to get that in a little snapshot. Pretty much anybody with chest pain will be given a triage category of 2, which means that they need to be seen within about 10 minutes. So a life-threatening illness goes triage category 1, need to be seen immediately, 2, 10 minutes. Now, those, that doesn't necessarily mean that they'll see a doctor in that 10 minutes, that particular patient, but they'll almost certainly have an ECG, and they'll probably have some blood tests to get the ball rolling, so to speak. And the ECG will be seen by one of the senior doctors. And this is because we're really focused on heart attack, because that's what's the most common thing that's going to kill people with chest pain is heart attack. And also, as David just said, that heart attack, because the aorta, as it dissects, can interrupt the blood flow to the heart. Effectively, you can have a heart attack as a result of a dissection, and that can look like an ordinary old heart attack, which is treated quite differently. So there's a few things to balance up there. So how do we decide what to do? Well, some of that has to be about clinical suspicion. You have to have it on your radar, as David said, you know. And examination, that's actually a much smaller part. Most of by the time you've got to examining a patient, because you have to do a focused examination, because there's not time to do a prolonged examination, you really want to have a good idea of what you're looking for first. And then we have to think about what investigations to do. And we've heard about CT earlier from Zub. There are a few other things that can help us to inform us to decide whether to do that CT. So these are very busy slides, but they're really just a demonstration. On the left you'll see a slide which is called the art of diagnosis. And I think most clinicians would still consider the diagnosis a type of art. And because it's a certain art form, there's an awful amount of error that you can put into that. And there's particular areas of cognitive bias and personality. So if you're overconfident, if you're seen lots and lots of one thing in the last month, you may be misled down one particular path. And it's very important for doctors to be very aware of what their biases are. A little flow diagram on the right, which is really just about decision making, and we all make decisions every day. Diagnosis is no different. You know, it's almost like what are you going to, any sort of identification. So for those of you who might watch birds or, try and decide what insects or what flowers and what, it's all about, well, does it look like a, daffodil, and then that's going to give you a particular route through. So if somebody's got chest pain, here are the things that I'm going to be thinking about. So under clinical suspicion, there are more detailed things about the patient's history. So risk factors, which we've heard about earlier, connective tissue disorders, previous operations, previous dissections, the age of the patient, all of those things play a part. Particularly the pain, we're classically taught that pain in aortic dissection is sudden and severe. It can come on at rest, which is not necessarily true. Most heart attack pain comes on with some form of exertion, not always, but mostly. And other symptoms. And this is where aortic dissection is really interesting because, as you just heard, as the aorta dissects, it can cause symptoms all over the body. So sometimes it's actually, this patient's got chest pain or back pain, but it doesn't feel right, it doesn't fit with one diagnosis. They've also got a funny, droopy face, or their arm doesn't move, or they've got pain in their tummy as well. All of those things can help make us more suspicious. So then we get to examination, and again, things are complicated. Your blood pressure can be high if you've affected the baroreceptors, the pressure receptors in the aorta. You can get a very high blood pressure. Patients may have a high blood pressure already. You can get a very low blood pressure because the heart's not working properly anymore. So there's a huge range there. It's the discrepancy that makes the difference though. So if it's blood pressure's maybe higher on one arm than the other, then that may make you think a bit more too. Now, investigations are really interesting. I don't know how many of you may have heard of a campaign called Choosing Wisely. Choosing Wisely is a current campaign run internationally about making sure that we're making the right tests for patients. So it's thinking about, does a patient need a particular test? What's that test going to show? And making sure that we're not doing too many. And as a result of that, of course, there's always a chance that we might miss things. Because it's getting this balance between over-investigation and under-investigation, and that can be quite tricky. So there are guidelines that can help us, and it's quite interesting to actually, if you're internet savvy and want to go and have a look, the Choosing Wisely website's a good one to look at. One of the things which has been a bit more interest lately has been the D-dimer test, which is a blood test. It kind of measures the amount of clot that's in the blood, kind of. And we do know that if you've got a low D-dimer, then your chances of having aortic dissection are very low. So that can help us in an emergency situation where we're thinking, what's happening with this patient? Should I do a CT scan or not? If I've got a low D-dimer, then I'm more likely to look for another cause, less likely to put the patient through the CT scanner. Also, ECGs can be very non-specific, not terribly helpful, but more and more emergency doctors are becoming skilled in bedside echo, so ultrasound of the heart, ultrasound of the aorta. That's tricky in an emergency situation, but I think we're going to see more of that sort of test in the future. So putting it all together, we're thinking about the clinical suspicion coupled with those high-risk features, particularly that abrupt onset, a variation in pulse, is there an abnormality in the X-ray? And there is an aortic dissection risk score which you can apply to patients, add that to a D-dimer, and then that can help you once again to decide whether or not to do a CT scan. Because we can't possibly CT scan 30 patients with chest pain every day, not just because we don't have the capacity of radiographers, radiologists and the CT scanner going, but also because it's not always the best test for everybody. And of course we need to think about what else could it be. So why do some things, things go wrong sometime? And David's already talked about the zebra, and I also was talked to, common things occur commonly. If it looks like a duck and it cracks like a duck, it's a duck. Well, sometimes it's not, it's a goose, And we need to think about those things. If you don't have that in your head, if you don't think what else could this be, then you're going to make a mistake. And the same with things like, cognitive bias. We need to be aware of our cognitive biases. And that's also where patients can help us. And so, are you sure, doc? Could it be this? Can I get a good explanation of that? And that's where partnership in medicine is really important, patient and doctor partnership. So I've got a particular interest in digital tech, and I thought, well, let's have a little think about what could possibly be happening in the future. And Omar talked a little bit about, genomics, and so far that hasn't been terribly promising in terms of predictability, but I think over time we will probably have more of a predictable way of looking at individual patients. So, what's good for so-and-so may not be good for such and such, depending on what their genetic biomarkers are. And artificial intelligence. I think this is going to be a really, really interesting field. And recently, a London firm made a little bit of noise over the fact that they had this artificial intelligence tool sit the GP college examinations and actually do better than the GP candidates. I know questions, not patients, but it gives you an idea of what could happen in the future. And finally, there's this saying of Confucius: the hardest thing of all is to find a black cat in a dark room, especially if there is no cat. And there's a few things in medicine that we will say, it's like looking for a black cat in a dark room. And aortic dissection is one of those, because it can be a really, really tricky diagnosis to make. And I'm going to leave you with it.